Hi, my name is Kacey Combs. I'm currently a student at Northwest Florida State College, and I'm also a nurse in a labor and delivery unit in Crestview. Today we'll be discussing delayed pushing in laboring patients in the second stage of labor. I chose this topic because I find at work that some nurses tend to delay pushing with their patients once they become complete during the laboring process, and some nurses decide to push right away. My PICO question is, in laboring women in the second stage of labor, would delaying pushing compared to immediate pushing during the second stage decrease the amount of time spent actively pushing and lead to decreased maternal fatigue in a 12-hour period? For my PICO question in my presentation, I decided to do a multi-base data search for my articles. I searched CINAHL, Medline, EBSCO, and Gale. I didn't find that many articles pertaining to my evidence-based practice question using the words delayed pushing, passive descent, and labor only because I feel that there aren't that many out there within the last 7 years. But I did come up with three great articles that I chose that I felt presented the best information for the topic at hand. Article 1. The first article I chose discusses delayed pushing versus immediate pushing during the second stage of labor for women with epidural anesthesia. So, the objective was to determine if delayed pushing during the second stage decreases the amount of time pushing and decreases maternal fatigue. The conclusion was that when you delayed pushing for up to 2 hours during the second stage, that the amount of time during the second stage of labor decreased by 27%. So the amount of time actually spent actively pushing was decreased by 27%. And when you're talking about a mother pushing for that period of time, it saves a lot of energy for her and decreases maternal fatigue significantly. Implications for practice. When applied to practice, the amount of time spent actively pushing in first time moms can be significantly decreased and decreases fatigue in the mother, and it also decreases nurse burnout. It's difficult to push with a patient for 2 or 3 hours at a time. When I critiqued this article, I found that some of the limitations were that the study did not evaluate which positions the nurses used during labor or what breathing techniques were used during this time. Also, since the women were only being checked every hour to decrease the risk of maternal infection, the exact time of full dilation of the cervix was not known. Some of the strengths of the study was that the study included a fair representation of the larger U.S. population, and the study was randomized. So once the women were completely dilated, they were assigned to either the control or experimental group, and this was to help decrease nursing bias. The findings was that there was a 27% decrease in the length of time mothers spent pushing. The average length of labor was only 59 minutes longer in the delayed pushing group, even though they were delayed 2 hours. So, really, they saved time there and a lot of energy. The data collection included education on a sterile vaginal exam, and timing was performed. A random computer generated number assigned the participants to a group. So, as we talked about before, that's when it was assigned. The research question or hypothesis was to determine if delayed pushing after the onset of the second stage of labor decreases the amount of time spent pushing and decreases maternal fatigue. This directly correlates to our PICO question. The second article that I critiqued was the effects of delayed pushing during the second stage of labor on postpartum fatigue and birth outcomes in first-time moms. So the objective was to determine if delayed pushing until the mother felt the urge to push during the second stage of labor resulted in decreased postpartum fatigue. Sorry, hold on one second. We found that the conclusion was that there was a significant decrease in postpartum fatigue both at 1 hour and 24 hours. The implication for this practice was that the study showed that maternal fatigue can be decreased during the postpartum period by implementing delayed pushing during the second stage of labor. So not only does it decrease the amount of time you're actually spending pushing, but it decreases postpartum fatigue, which is especially important when you have a mother that needs to care for a newborn baby. The measurements were performed at both 1 and 24 hours using the maternal fatigue symptoms checklist. The research question or hypothesis that this article proposed was, does delayed pushing during the second stage of labor decrease maternal fatigue at 1 and 24 hours after delivery? The design and method was quasi-experimental design, and the data collection included the staff and patients being educated on when to begin pushing. And as I said, the scores were computed using the modified fatigue symptoms checklist. The findings was that they found there was a significant decrease in maternal fatigue both at 1 and 24 hours. The strengths of this study were that the pushing methods were monitored and the demographics and obstetric values and variables were controlled in each group, which is especially important. As we saw in our study before, those were not monitored and they could have had effects on the study. The limitations was that the trial was unable to randomly assign the participants to the control group or the experimental group due to ethical concerns. So the mothers were allowed to choose which group they preferred to be in during this experiment. The third article I critiqued is called A Review of Evidence-Based Practice for Management of the Second Stage of Labor. This article was a systematic review of studies and meta-analysis that had been performed prior. The objective was to weigh the risks and benefits of interventions during the second stage of labor to provide optimal care. Again, this pertains to the second stage of labor, and we're concerned with delayed pushing and how it affects maternal and fetal outcomes and fatigue. The conclusion was they found that there was an increase in vaginal births and a decrease in the amount of time spent pushing when the mother delayed pushing until she felt the urge to push. So again, we found through the systematic review that the amount of time spent actively pushing was significantly decreased. We also found the increase of vaginal births was increased by 10%, which is large when you talk about our national C-section rate of around 30% in the United States. Implications for practice. The implications is when the best evidence is reviewed and applied to patient care, we see the best outcomes for the mother and the fetus. And this is really important in all healthcare, but especially pertaining to moms and babies. The design method, as we talked about, was systematic review. The data collection, there were 8 RTCs reviewed and meta-analysis that were reviewed and compared to find this data. As I said, they found a 10% decrease in vaginal births, and they also found that when delayed pushing was implemented, more unassisted vaginal births, decreased perineal trauma, fewer fetal heart rate decelerations, and higher 1-minute APGARs were noted in these patients. So again, when you're talking about fetal health and maternal health, this is a great reason to delay pushing for up to 2 hours after the cervix is completely dilated. The strengths of the study was that it was a systematic review of evidence and literature that provided optimum patient care and recommendations based on the evidence and practice. The woman that wrote this article, she had no disposition either way. She was just trying to find the best optimal care for her patients. The limitations of the study was that the systematic review included analysis of patients with several different variables in each study, such as some of the studies included all patients with epidural analgesia. Some of the studies, none of the women had epidurals. And maternal positioning was also different in each of the studies. And those are big factors when you talk about delivery and the amount of time spent pushing. So that was one of the weaknesses. This is an especially important PICO question when you talk about application to practice. Today, in a lot of rural labor and delivery units, it's hard to implement evidence-based practice into everyday care. When you talk about delayed pushing in first-time moms, it's important to implement it and to try to get people on the unit on board with delayed pushing until they feel the urge to push. As we talked about, this decreases the amount of time actively spent pushing, and it also decreases maternal fatigue, which in turn would play a part in postpartum depression and anxiety. Delayed pushing increases the chances of the mother delivering vaginally and decreases the chances of an instrument-assisted birth. As we know, this is the best and safest option for not only the mother but also the baby. So this is important when we talk about delayed pushing. You have a 10% increase in vaginal deliveries. Delaying pushing decreased maternal fatigue significantly, both at 1 and 24 hours postpartum. Again, when we talk about postpartum anxiety, postpartum depression, postpartum fatigue, this is very important. This will help the mother save some of her energy to help spend time with her baby and her family. By implementing evidence-based practice into patient care, patients receive optimal care and outcomes during the second stage of labor. Really, this is the most important thing for our patients. We want to give them optimal care and the best outcomes possible for them and their children. And it's every nurse's responsibility to implement evidence-based practice and bring this to the workplace. Barriers, kind of as I was hinting at on the last topic, we've always done it this way, and that's what a lot of nurses say, especially a lot of seasoned nurses that have done this a long time. When new evidence-based practice comes into care, it's hard it's hard to implement these changes in the workplace. Also, we have physician preference. Some physicians, once the woman hits 10 centimeters, they like to begin pushing immediately. That way they can get back to clinic or other things that they need to do that day, and they want to be there for the birth, obviously. So physician preference is something we need to tackle as well. Patient preference. It's difficult to tell a patient that they're fully dilated, but that they need to wait up to 2 hours to begin pushing. Especially with first-time moms, it's hard for them to understand that waiting can actually be more beneficial for them and their children. So these are some barriers that we'll need to work on. I hope that you enjoyed my presentation today and you learned something about implementing delayed pushing in the workplace. Thank you.